I would like the chairpersons, Dr. Arnab Gupta, Dr. Abhimanyu Basu, Dr. Suvadip Chakrabarti, and Dr. Manish Mandal. Can we have in the stage, please?
Good afternoon, everybody. I think we are right on time, in fact, before time. So we would happily move on to the next session. And we have none other than Dr. Avinash Saklani from TMH Mumbai, who's going to talk about LAP LAR, the sticky points. Right.
Hi, good evening, everyone. Great to see such a great crowd. I would like to thank IASGCON for this, and good to see so many friends, Arnab, Manas, and everyone else. Congratulations on a great thing. I think my talk today is about LAR, the sticky points, but there's so many points sticking out, I don't know when I should end this slide. So unfortunately, unlike the last presenters, I should have a series of videos. So this one is a 51-year-old chap. Growth is 8 centimeter from the anal verge. Biopsy is moderately differentiated adenocarcinoma. And MRI looks like T3 and 0. So normally after bowel positioning, we use 5 ports and we do the inferior mesenteric vein dissection and followed by dissection along the inferior mesenteric artery. I think most of the dissection is done with a monopolar, and then we enter the TME plane. What we do is then create a seagull sign, so the inferior mesenteric artery is bared. You can see the white line being dissected. Sometimes if the sigmoid is very redundant, then we can mobilize it laterally. You go up to the splenic flexure. I think for all low anterior resection, a complete splenic flexure is required. And you enter the lesser sac. What we do is we put a tape around the rectum and use a fan retractor by Medtronic, so you can do a posterior dissection. For any tumor which is palpable, we try to go down to the pelvic floor completely and see the levator. I think that is the best way for getting the stapler. So here you can see the anococcygeal raphe. That is very important. If your staple doesn't go down, because this V of the levator or anococcygeal raphe is not cut. So not only for intersphincter dissection, for staple low rectal anastomosis, you need to go down and transect these things, and the rectal tube becomes completely bare. Sometimes you can ask your assistant to do this as well. The anterior dissection, you take off the peritoneal fold, you cut it slightly higher up so you have good control. It's like a love handle, so you push the peritoneum, you find the plane there. So here you can cut the Denon-Villers fascia, you have the inferior hypogastric plexus there, you try to preserve that and you go down to the pelvic floor. So first thing you do posterior dissection, then anterior, and then you go laterally. So rectal tube has to come out completely up to the pelvic floor. Again we do the same dissection on the left side. Once you dissect anterior and posterior, the lateral neurovascular bundle is seen and you just transect it. So most important, the rectum, you have to reach up to the levator or you reach the intersphincteric plane. So the rectal tube is completely bare. You should have about 3 or 4 centimeter of the rectal tube to transect it well. So you can find the intersphincteric plane posteriorly. You can see the V of the levator there. And once it is completely bare, your rectal tube is completely bare. And then you can fire a stapler well across there. We divide the inferior mesenteric vein because it gives additional length, as my colleague said earlier on. We don't always take the whole inferior mesenteric vein out because it doesn't contain any nodes, but it gives you good length. To a small incision in the left iliac fossa, the colon is withdrawn. And the rectum stapled. I'm not sure whether it's playing at double speed because it seems to be going really quite fast. And then the anastomosis is performed. You look at the lie, the orientation, and you do a leak test. But all cases are not that standard. Sometimes you may have planned this. These are locally advanced rectal cancer. You given them chemoradiation and you wait for the response. But despite that, it hasn't responded very well. So you do TNT, you give consolidation chemoradiation, and the tumor still doesn't look good. So you go back thinking it will be standard anti-resection and it doesn't look good. So okay, you can see the sigmoid is stuck to the rectum. This looks quite locally advanced, looks almost fixed sort of thing. So here you have to just follow the ring. Again, you follow the same plan. You go along the inferior mesenteric vein. For the artery, instead of starting at the groove or promontory, you go along the inferior mesenteric artery. So you have to realize you will not have very straightforward rectal cancers all the time. So sometimes you have to go beyond TME or extended TME. So here in the cut, you're going along the iliac vessels and mobilizing the peritoneum. And then you reflect the peritoneum completely off. So some people would want to do a peritonectomy for HIPEC procedure, so we do it all the time. For good mobility and for good views, we start again from the left side and we enter the plane. So the lateral dissection of rectum is slightly more difficult. And from the lateral side itself, we come posteriorly. As it is an extended resection, you have to see the ureter, and that's the most important thing. So on the left side, while going around that, we trace the ureter. You identify the vas. We realize actually it is going to the seminal vesicle. So here you dissect the ureter and cut everything above that. We are going to cut both the seminal vesicles. All the medial structures, the hypogastric nerves, the vessels will all be transected. Similarly, we took a cut anteriorly as well. On the right side, again you trace the ureter there. You see, sometimes we are surgical oncologists, so we tend to cross boundaries and go into other organs. But just because you are a surgical gastroenterologist and you get a locally advanced tumor, you will have to do it at some point. So here you dissect the ureter, you are cutting off the hypogastric nerves. He will have urinary dysfunction, but he can live with clean intermittent catheterization. We cut both the seminal vas deferens now. And then you dissect. So there's a good plane with between the seminal vesicle and the bladder. So this is the view that you require, where the ureter is going up and seminal vesicle going down, vas deferens. Then you take the thing. So a rectum which was looking relatively fixed, you mobilize it posteriorly by going outside the presacal fascia. You've seen the ureter and modulizes laterally, and anteriorly you've taken the seminal vesicle, so now it's completely mobile. And sometimes you have to change your plan. So plan initially may have been for a low anterior resection, which you can do. Here we've done the IMA as the last part. So just in case if you require an exentration patient isn't consented, you can just go back. Again you do medial to lateral mobilization, go down to the pelvic floor. So the fan retractor V of the levator has to be seen always. In this case actually after mobilizing completely down to the pelvic floor, we felt probably it's too advanced a tumor to join him back, and we converted to a Hartmann's or API procedure. But just for you to know, sometimes you may not always have the plane beyond TME. They are all anterior resection, but they are called extended TME. So I wouldn't recommend it for everyone. Sometimes you can convert to open procedures to avoid things like that. But I don't think I can see anything better in lap than this one. Now all of these are very straightforward procedures, look very good, but things can go wrong. So let's look at it. We are doing the same procedure. This is your dissecting along the inferior mesenteric vein. So it's one of our fellows. We have 3 fellows and we are a good training unit. So some of them are operating and you see some of the veins bleeding out. And the initial thing is to clamp and then try to burn it off with energy devices. So I think getting a good plane and good dissection is very important. Just putting an energy device, if you get bleeding, obviously we all know the golden rule of surgery. It may not work, and suddenly all of a sudden what was just a small bleed has become a major disaster. And then obviously you have to call someone in. So best thing to do is to put a pack in there. So I think the senior surgeon comes across, and then you find the plane below so you keep the pressure on the bleeder there, and you find the plane below the IMA. So now you know you're not cutting off everything else. You can also find the plane on top of the IMA. You dissect in and you find it's just a small bleeder there. The best important thing, use your left hand, put a clip there. The other thing happens is when toward the end of the procedure, you've gone down to do a APR and patient has suddenly collapsed. So you don't think it's vasovagal, it could be surgical. Some clips have come off. Here you can see, suddenly you come up into the abdomen and just check out how things are. Find the bleeder and clip them. So we do about 450 rectal cancers, so don't think this happens every day, but there are few of these events there. Here this is a classic clip. You pull the gauze piece out and all the clips have come out here. So be careful. Even the most accidents happen toward the end of the journey, whether you're driving or in surgery itself. So never take it cool. You can change teams in between. Your registrar can do the last part. It's always better to take 1 centimeter of the stump of the IMA. When you do that, it saves the nerves, as well as if things were to go wrong like this, you can do it. But best thing is to have a good team, steady approach, and your left hand has to be really steady actually. And then again, no clamping there. Dissect it well, hold the artery well, and you can put a clip on it again. Nowadays, I think we do look lateral pelvic node dissection quite a few, and the bleeding here can be quite horrendous, and suddenly you will see a clean field becoming a pool of blood there, and you normally do the same thing, pack, dissect, finish your dissection there, and then you can find the bleeder. So again, to be done at centers who do it routinely. The other thing now you do, you want less and less incisions. So what you do specimen extraction from the ileostomy site itself. So once you do this procedure, you take the tumor out, you create a site of ileostomy. You make it wide, because why two separate incisions? And then the specimen doesn't come out as much. And then you go, when you put this back in again, and you see the length is not enough, and you mobilize quite a lot. And then you look back, in your movement, I think the colon has got twisted here. So which has to be untwisted. So very careful. So you don't have enough length, there is some other reason, have a look at it. You twist it completely again, you have to see the mesentery has to be in the right side. The anti-mesenteric colon has to be on the right side, and suddenly the length which was not there is there enough. So these are all very simple procedures there. But as you do more and more, you see more problems there, and then you can correct yourself and improve your outcomes. Thank you.
Thank you, sir, for an excellent presentation, and also the intraoperative injuries that take place, that has to be taken care while doing the surgery. Excellent presentation, sir.
Thank you.
Avinash, excellent presentation, and thank you for showing how to manage them coolly. I just want to compliment you.
Thanks, Jagdish. Thank you very much.
Thank you, Dr. Avinash. I must tell, we started way back in 2005 doing lap colorectal, but even now, yesterday also we struggled, especially if you have a very difficult case post neoadjuvant chemoradiation. The planes are quite difficult, and you don't know how much to proceed, and even after opening up, it's a bigger challenge because the access is so much difficult. And the complications that you showed and how coolly you managed is also commendable. Any question from the floor? Dr. Jagdish, do you want to ask something? No? You're okay. Thank you very much. Wonderful presentation.
Thank you very much. Take care.